A 50-year-old man came to the operating room for a colectomy. After the induction of general anesthesia, endotracheal intubation was attempted unsuccessfully by a physician in training. The tube was placed in the esophagus and immediately recognized by the anesthesia care team. When esophageal intubation occurs, temporarily leaving the tube in the esophagus until the airway is secured should be considered. This is particularly important when patients have a full stomach or when regurgitation through the tube placed in the esophagus is obvious. Ventilation with a face mask is possible, as demonstrated here. The tube can be placed to the side and the gap sealed with the face mask. The danger in removing a tube placed in the esophagus is that gastric contents may follow the withdrawal of the tube, possibly causing aspiration. On the other hand, leaving the tube in the esophagus may make face mask ventilation difficult and may obstruct the laryngoscopic view. Some might argue that leaving the tube in the esophagus may actually facilitate proper endotracheal tube placement by indicating the location of the esophagus. In this case, the first tube was left in the esophagus, the patient was ventilated with a face mask, and after a second laryngoscopy, a second tube was properly placed in the trachea. Laryngoscopists must use their clinical judgment when removing a tube from the esophagus.